My name is Molly. I'm part of the Department of Family and Community Medicine at University of New Mexico in Albuquerque. And this is part of our resident school that we usually have on Wednesday afternoons, but we've invited some extra folks. Super happy to see residents and super happy to see extra people too. Welcome. This is just an absolute privilege and honor to welcome two amazing people that if I start fanning myself, it's because I'm fangirling for both of them. Dr. Stephen Porges and Dr. Marilyn Sanders are here today to discuss the polyvagal theory. So the polyvagal theory is something that some of you may have heard of and some of you may not have. It has literally transformed what we understand about trauma. You cannot read an article or a book or go to a conference. You really can't interface with any kind of academic or practical trauma studies interface without hearing about the polyvagal theory. And it's not just a marginal mention. People are really understanding the transformative power of understanding polyvagal theory and how that affects many things, including trauma. Dr. Porges developed this theory, and he is here today to discuss this with us. He is a distinguished university scientist at Indiana University. He is the founding director of the Traumatic Stress Research Consortium. He is a professor of psychiatry at the University of North Carolina and is professor emeritus at University of Illinois in Chicago, as well as the University of Maryland. Dr. Sanders was possibly the first physician to recognize the power of polyvagal theory, the transformative revolutionary power of polyvagal theory as applied to clinical work in her work as a neonatologist. And she has now published quite extensively on clinical application of polyvagal theory and has an upcoming book that I'm very excited to get my little hands on to learn more. She is a professor of pediatrics at the University of Connecticut School of Medicine and is active on the Pediatric Ethics Committee. So thank you so much, all of you, for being here. We're going to start with Dr. Sanders just giving us the basics of the polyvagal theory. We're going to hold questions until after she is done, and then we'll have question time. And then following that, we'll have a question and answer time with both Dr. Porges and Dr. Sanders. Take it away, Dr. Sanders.
Excellent. Molly, thank you so much for the very kind introduction. Thank you both for inviting me to speak today, along with Stephen, and many thanks to several people that I want to mention. Of course, Dr. Stephen Porges, the developer of the polyvagal theory and a mentor to me over the last almost 10 years now. I would also like to thank Randall of the Polyvagal Institute for bringing me together with Molly, and Jerry for recording this. In 2012, a colleague and friend gave me Steve's book, his original book written for Norton, and said that he thought this book might be right up my alley and asked me if I would be willing to review it for his journal. I eagerly said yes, and in the course of reading the book and writing the book review, I realized that the polyvagal theory was going to be foundational to my work as a physician and gave me a philosophy of care and an academic understanding and support for things that I had known viscerally as a physician, but had been unable to name, didn't have a language for, and therefore was not really able to communicate well to others. So with that, we will go on. I have nothing to disclose. Steve receives royalties from Integrated Listening Systems Unite for the Safe and Sound Protocol. I have some formal objectives for the talk today. We're going to talk about the evolutionary framework for the development of the autonomic nervous system. We're going to talk about the 3 neuroceptive states of the mammalian autonomic nervous system. And we're going to talk about opportunities to improve the doctor-patient relationship based upon an understanding of the mammalian autonomic nervous system. But here's what I really want you to take away from this, otherwise known as my crystal clear objective. I want you to be convinced and to understand that what you, as a physician, feel in your bones and in your gut impacts your patient's experience. Well, why does it matter? It matters because your patient's life depends upon it. And I think that we should say even more than at any other time in this difficult COVID pandemic time, when all the features of safety are so often lost in both our professional and personal conversations and relationships, being able to understand how you can bring safety to your conversations with patients is absolutely critical. On the left, you actually see a mother that I spent a lot of time with when she was in the NICU with her preterm babies. And the picture that you see here was quite typical. We spent quite a bit of time actually in physical proximity to each other. Well, why did that help? Why did that work? Nobody illustrates things better, I think most of you would agree, than Norman Rockwell. And this is an old Norman Rockwell photo where you see a physician leaning into his relationship with a mother and her young child. Please notice the physician's posture. Please notice the mother's rapt attention on him. Please notice that he even has the baby looking directly at him. Herbert Adler, who is both a family physician and a psychiatrist, has written a beautiful article on the sociophysiology of the doctor-patient relationship. And in the course of that article, Dr. Adler says that developing physician-patient relationships requires the person-to-person attunement that is essential for the development of the newborn. Well, that brings, of course, us to talk about what are the biological expectancies of the newborn and the young infant. Babies and young infants expect their providers to be in physical and emotional proximity to them. They expect them to be sensitive to them. They expect them to be attuned to them. They expect them to engage in contingent responsiveness. In other words, baby makes a cue, mother picks up the cue, she does something back, baby picks up the cue, and they are in synchrony. And over time, of course, this social engagement leads to social connectedness. The problem, particularly today, is that the environment of our care, the care we are providing to our patients, is often a mismatch of expectations, a mismatch of evolutionary biological expectations. So the same lady that you see, the older lady that you see here delighting in what looks to me like a roller coaster ride or something like that, the next day could be in an emergency room like the one on your right, with all the facial cues gone, with the prosody and the cadence gone, trying to figure out how to find safety in the environment. We're going to use social connectedness in a very specific way in the course of this talk, the way that Steve Porges uses it in his work. And Steve defines social connectedness as the ability to mutually, that is synchronously at the same time, and reciprocally in a back and forth fashion, regulate physiological and behavioral state. And I want you to pause for a second and think about that term regulation, because we're not just talking about two people being together. We're talking about a social engagement that happens in a very specific way. So whether you're the father with his young child on his chest, or the older person in the care of a younger person, or the young lad with his golden retriever, there is co-regulation going on there. Steve goes on to point out to all of us that social connectedness is a biological imperative for mammals. Young mammals cannot survive without their adult caregivers. So whether you're the chimpanzee infant, the lion cub, my own favorite, the golden retriever puppy, or this beautiful mother and her child, you can see the connectedness that is going on. And you don't need to know anything about this mother or about this infant to recognize that there is a very special relationship happening now. So as we think back from an evolutionary standpoint, earlier in the course of evolution, of course, everything was focused upon being safe from danger and life threat. And one of the things that Stephen talks about in the course of his work that I really enjoy and have been thinking more and more about lately is the idea that the social engagement system repurposed the autonomic nervous system, repurposed it from a system that was meant to scan for danger or life threat to a system that was meant to look for safety and security. As we look more closely at the evolutionary biology of the autonomic nervous system, and I want to credit obviously both Steve and my friend Deb Dana for the graphic here, when the first vertebrates came on land, reptiles, as you see in this picture, when the reptile sensed danger, the reptile had only one response. All the reptile could do was immobilize, try to blend in, try to be as small as the reptile could possibly be to avoid the predator. And that response was essentially generated by the parasympathetic dorsal vagal complex, deep in the brainstem in a more dorsal or posterior position. But as evolutionary biology proceeded, an evolutionary hierarchy developed that moved us, or moved other vertebrates, I should say, from simply immobilization to being able to mobilize with the sympathetic system coming online. So the fish, for example, when there's danger in the midst, can mobilize, can scatter, can flee. But it is only mammals through the parasympathetic ventral vagal complex who can use social engagement to try and manage an upset of the autonomic nervous system when the autonomic nervous system senses danger. So when you think, for example, about young children, what's the first thing a young child does when he or she senses that something is wrong? They look for their parent or other caregiver. Now, the brain reacts in a particular way to severe, or as we call it in pediatrics, toxic stress. So not all stress is bad. We all know that. I mean, stress is involved in maturation and development. The first time a baby takes a few steps, it's stressful. But when that stress occurs with the scaffolding of a sensitive caregiver, it actually leads to growth. But what happens when there is toxic stress? Toxic stress on a chronic basis. And toxic stress, of course, is a severe stress that occurs without the scaffolding of caregivers. You are alone. And over time, toxic stress, if it is unrelieved, has a clear-cut impact on brain development, so that we know that the amygdala, the alarm system of the limbic system, first hypertrophies and later atrophies. We know that the hippocampus atrophies over time, and the hippocampus is, of course, where memory is both stored and retrieved, and the prefrontal cortex atrophies. And the prefrontal cortex is, of course, the site of organization and planning, where alarms from the limbic system are processed before going to the frontal cortex for interpretation. So Steve, in his development of the polyvagal theory, went yet another step, thinking about this evolutionary hierarchy of behaviors, of immobilization, mobilization, and social engagement. And the next step that he went to, and I think that this is particularly important for those of us who are in helping professions, certainly for those of us who are physicians and other healthcare providers, is to help us understand that even behavior that appears at first glance to be maladaptive is in the service of survival. So what we know is that our autonomic or unconscious or out of consciousness nervous system is constantly taking cues from both the external and internal environments. So there's a sensory experience that goes on around us, depending on what the sounds, the lights, all of those things that may very well be out of our control. There's also a relational experience that's going on in the environment. And then, of course, there is an internal sensory experience, otherwise known as interoception, which is essentially the visceral response to what is going on outside of us. And it's really interesting because we have always had idioms and metaphors about this. We talk about people feeling it in their gut. I feel it in my bones. My heart is breaking. But it was putting this together and understanding that both the external and internal sensory experiences led to a response of the autonomic nervous system, which Steve has named neuroception. That is a good portion of the brilliance of the polyvagal theory. So neuroception is essentially our out of conscious awareness of whether we are safe, in danger, or literally in a life-threatening experience. And I want to point out and emphasize that it's not a linear relationship. We can also go back and forth between safety, danger, and life threat. So as I mentioned, neuroception, which we'll be referring to a number of times in the course of this talk, is the unconscious awareness of safety, danger, or life threat. And it takes place through the 10th cranial nerve, the vagus nerve, or wandering nerve, as it has been called because of its many branches that serve the body both above and below the diaphragm. So the organs above the diaphragm are by and large served by the ventral vagal complex. The organs below the diaphragm, the stomach, the liver, the intestines, are served by the dorsal vagal complex. And these are the organs, the viscera, that are so critical for metabolism and homeostasis. So I don't want anybody to think that as we move forward that dorsal vagal is bad. No, dorsal vagal has a very important point in our lives in terms of maintaining homeostasis. But one thing that you may not realize is that 80% of the vagal fibers are actually afferent. Yes, there is a significant efferent component of the vagal nerve, and we see that very directly, for example, in the vagal nerve's importance in regulating heart rate. But it also brings sensory information back to the autonomic nervous system for processing. It's a matter of location, location, and location. Where does all of this come together in the polyvagal theory? Well, as we have evolved, the nuclei of the trigeminal, facial, glossopharyngeal, and accessory nerves are all in the brainstem in the proximity to the vagal nerve that you see here. So what does that create? What that creates is essentially a location in which there are affective sensory signals coming back and what are known as special visceral efferent signals that are essentially controlling our facial muscles, our facial movement, our pharynx, and together those send a neuroceptive message to the SA node that you see in the figure on the right that is involved in regulation of heart rate. And this is something that Steve has referred to as the face-heart connection. So what we are going on and what we are seeing, for example, in someone's facial expression or their prosody or their cadence causes us to have a response in our autonomic unconscious nervous system that impacts our sense of safety felt through either our ventral vagal complex, sympathetic system, or dorsal vagal complex, with impact on our heart rate and the variability of our heart rate. Fortunately, through the work of Steve and others, there is a way of measuring ventral vagal tone. And we measure ventral vagal tone through a measurement called respiratory sinus arrhythmia. While this is akin to heart rate variability, it is not exactly the same. And it's important to keep this in mind, the difference between the two, because heart rate variability merely measures the distance between RR complexes. That's all. Whereas respiratory sinus arrhythmia, and Stephen can certainly talk about this a little later because this is obviously one of his areas of enormous expertise, integrates the parasympathetic component. So as we all know, when you inhale, when you take a breath, your heart rate speeds up a little. Whereas when you exhale, your heart rate, which is now under parasympathetic control, slows down. And this is the basis of many of the voluntarily regulated breathing practices that some of you may be familiar with. But if you want to think about a way that makes sense to you from your medical training so far, I would ask you to think about what you might know about heart rate variability in your obstetric and gynecology rotation. So you all know that one of the key measures that OBs are looking at in terms of deciding about whether a delivery is going, a labor is going well, going smoothly, is variability. That's what they're looking at. They are looking at essentially RSA. And when there is marked variability or moderate variability or even average variability, that means that the fetus is able to respond to stress. The fetus is doing well during the process of delivery and labor. However, you also know that when variability begins to diminish, people start becoming more concerned. And as variability diminishes, the fetal heart rate often becomes tachycardic. And ultimately, if no one interferes in this, by interfering, I mean get the baby delivered, there may be absent variability and deep bradycardia from which the baby cannot be resuscitated without significant intervention. Another concept that we need to talk about, and again, Steve can talk about this in much more detail and with eloquence than I can, is the vagal brake. And the vagal brake is an interesting concept, a fascinating concept, and an important concept to understanding polyvagal theory. So the vagal brake is essentially what is operating at the face-heart connection at the level of the SA node to either allow for more sympathetic energy or not. So, as you know, when you are engaged, for example, in a conversation, and when you are enjoying yourself and when you are becoming excited, you've got to have some metabolic energy to engage in that conversation. So the vagal brake is in the process of coming off to the point that at some point you reach an optimal level of vagal brake release. That lovely combination of parasympathetic and sympathetic activity working in tandem that allows what the psychiatrist would probably call an optimal window of tolerance. However, there is a point at which the vagal brake can disengage too much. And when you think about your work on the wards and your work watching doctors, nurses, patients, there is a point at which, essentially, if the vagal brake comes off and completely disengages and people become sympathetically activated, they lose the ability to essentially engage in conversation, to engage in discussion, and to process information. And unfortunately, if that disengagement goes on for too long a period of time, and if whoever is involved in that interaction truly senses life threat, the dorsal vagal complex takes over and they shut down. They may dissociate in the psychiatric sense. They may simply leave the room from a psychological standpoint. So once again, the face-heart connection that you see here and the vagal brake are two concepts that are critically important to understanding how the polyvagal theory impacts our relationships. So I asked you in COVID time, which picture regulates your autonomic nervous system? The picture on the left or the picture on the right? They are both me. The picture on the right was taken at the height of COVID after I had just gone into a room to talk to a mother who said to me, "I just wish I could see your face." So how does this play out in the clinical setting? Well, in the clinical setting, when we have that sort of optimal release of the vagal brake, and when we are fully in the social engagement system, we show it in our facial expression, we show it in our vocalizations, we show it in that we are able to listen, and when we are in ventral vagal safety, we foster calm, both by inhibiting the sympathetic influence and blunting the HPA axis. I don't know whether some of you recognize this picture. It's one that's actually very precious to me. This is a picture of a neurology resident who came back to rotate in a newborn intensive care unit. The woman who is standing to his left is a nurse who cared for him when he was a preterm infant in that NICU some 30 years prior. And I think that you can see the way the two of them are in proximity, so comfortable, that this is a pure ventral vagal engagement going on. And of course, over time, in the face of ventral vagal safety, you can have attachment and love. Now, what happens, on the other hand, if you are sympathetically mobilized or in fight and flight? I assume that Netter is still used in medical schools, and nobody showed this better than Frank Netter, of course, who himself was a physician and a medical illustrator. Well, as you know, when we are sympathetically mobilized, we are aroused with dilated pupils, inhibited excretory function, mobilized muscles. So think of, hunter-gatherer societies, for example, when people really had that limbic system going and were hypervigilant and hyper-aroused, looking for the next critter to come around the corner. And babies, too, show sympathetic mobilization, although their ways of showing it, their behaviors are very different than ours. They show it with crying, with protest, with gaze aversion. And tragically, when we are in dorsal vagal danger, in life threat, terrible things can happen. We become vegetative, we become passive, we become reflexive, we shut down, we blend in, we may engage in addictive behaviors, we may engage in self-harm or even tragically suicide. And I assume that you all recognize this picture of the beautiful Dr. Lorna Breen, who was a medical director of an emergency room in New York City at the height of COVID, and simply could not take the losses that she couldn't prevent, and took her own life tragically. So let's talk now about applying the polyvagal theory in the doctor-patient relationship. My dear friend Deb Dana talks about the automatic autonomic ladder. And we have to think in any particular interaction, where are our patients and their families? Where are we? Are we safe, connected, calm, and social, literally at the top of the ladder? Do we feel in danger, mobilized, like we need to take action? Or are we in life threat, trapped, shut down, collapsed at the bottom of the ladder? I actually used this particular metaphor one day when I was talking with a group of our staff about the polyvagal theory, and I talked about it saying, I hope none of you right now feel like you are in life threat or trapped. And a very kind nurse looked at me straight in the eye, engaged me, and said, oh, Dr. Sanders, I would never leave you at the bottom of the ladder. So the question becomes, can my autonomic nervous system speak to your autonomic nervous system? And to do so, just as we talked about earlier with infants, we have to become a predictable, regulated presence who can be trusted. When we think of self and other in the doctor-patient relationship, we need to realize that we are tuning and toning two autonomic nervous systems. So I would ask you to think about whether you invite your patients to discuss their concerns. Do they feel safe and secure in their relationships with you? And do they feel their contribution is valued? How can we convey safety and security? We need to maintain physical and emotional proximity. We can't be standing across the room, halfway out the door, as the patient is trying to tell us their story. Unfortunately, this is one of the things that COVID too has interfered with, but there will be a time beyond COVID. There will be. And it's important to keep these things in mind and not lose these things. And even as we are still in the midst of COVID, to think about how we can accommodate and change our behaviors to continue to leverage our relationships and to convey safety and security. You can explicitly state your availability, and I cannot stress how important this is. I will often, as I'm going off for the weekend, we do 5 days in a row and then go off, say to families, I'm going to be gone for the weekend, but Dr. Moore and Dr. Trasky will be on. They know all about Jimmy, and they know how to reach me if they have a question or concern. And then engage the safety circuit because it's iterative. Once people feel safe and secure, they feel socially connected, which leads them to feel more safe and secure, which leads to attachment behaviors. And yes, patients and doctors can attach, and it's a beautiful thing when they do. And how do we do this? We maintain appropriate eye contact. We do it with our facial expressions, with a soft smile, warm touch, if welcome. And we all have to understand that there are certain situations in which touch is not appropriate, and with our prosody and cadence. And then as a physician, we are all leaders. And when the stakes are high in your office or on your floor or in your unit, people need us to be a ventral vagal anchor while they are sympathetically activated. And we can do this in a number of different ways. And I credit my co-author on the book, George Thompson, for this lovely figure. We can filter and metabolize threats so that we can step in if we see somebody is struggling and is becoming sympathetically activated. We can change the environment. We can take a person out of the immediate environment, for example, where they're becoming sympathetically activated. We can create and maintain a ventral vagal tone. So it's about what you're feeling in your gut and in your bones that is going to set the stage for the way other people behave, because they're going to be looking to you as an anchor, particularly in a crisis situation. And then, of course, we can behave in ways that enhance teamwork. It's also critically important to recognize and address neuroceptive entanglements. Ideally, when we're working with our colleagues or working with our children or working with our spouses, we're looking at two puzzle pieces fitting together. Unfortunately, when there are disruptions of connectedness, we can all too often either end up in a finger pointing situation or a knockout, and neither of those benefit anybody involved, and they certainly don't benefit your patients. And if you do become sympathetically activated, reflect on it. Be authentic with the people with whom you were with. Own it. Apologize and understand that none of us can be a ventral vagal anchor all of the time. So I hope in the course of our discussion today that I've given you an overview of polyvagal theory, an overview of key concepts, an overview of its power, and I hope that you have come to believe that what you feel in your bones and your gut impacts your patient's experience. Thank you so much, and I will stop share at this point.
Thank you so much, Dr. Sanders. I think now would be a great time if anybody has questions about the theory itself or about application to ourselves and to our patient-provider relationships. A question that I hear a lot, actually, and I don't know if anyone else has this question, is in what ways does this add to our older understanding of the autonomic nervous system?
Well, let me start on that.
Okay.
I'm not. The older views of the autonomic nervous system basically proposed a paired antagonistic model. We got the sympathetic as an accelerator and the vagus as a brake, and then it went on to say that the vagus and the parasympathetic supported homeostasis and the sympathetic didn't. So it gave you a very partial view. It didn't provide you with any information about the hierarchy in which our autonomic nervous system reacts to threat. And it works in a real interesting hierarchy in which our newer circuits inhibit older ones. That's totally polyvagal. And that is this newer ventral vagus social engagement system. When it's retracted, then our sympathetic nervous system becomes unimpeded. And when the sympathetic nervous system becomes dominant, it inhibits the dorsal vagus. So when you find that people who are highly mobilized, anxious people who appear to be under threat all the time, workaholics or people trying to regulate through activity, they end up with their gut not working because the active autonomic nervous system in that state inhibits the dorsal vagus. So what the model provides you with is a way of predicting symptomatology. So if you don't have your ventral vagal system on, then the rest of the autonomic nervous system is really vulnerable to act in defensive states. And this is all of internal medicine. We have to start understanding that our body regulates well in homeostatic functions if and only if the autonomic nervous system is not recruited in defense. So we have to be aware of what does that really look like. It looks like when the ventral vagal circuit's not working. And let me just add one other point to this. When you study both the maturation, and for Marilyn, it's very clear as a neonatologist, you study preterm babies, and you really have the opportunity to see that transition from a reptilian autonomic nervous system into a mammalian one. So there's the whole notion of flat facial affect, the intonation of a preterm baby's cry isn't full, and the vulnerability to bradycardia and tachycardia without respiratory sinus rhythmia is right there. And you can see that nervous system just sitting there vulnerable, and that it can never truly experience safety until that ventral vagal system starts to mature. So what you have to do is remove threat. But as Marilyn will tell you, working in a NICU, it's impossible to remove the cues of threat. The acoustic cues, the activity cues, are threat cues, even for the finest, well-regulated nervous systems. And now you have a preterm who doesn't have those resources.
So I might add to that, that I knew that I was hooked on this, so to speak, when I read one of Steve's earlier papers that talked about the vagal paradox. So in the NICU, and I don't know how many of you might have ever rotated through the NICU, but one of the problems that the preterm infant has is pauses in breathing and heart rate, apneas and bradycardias because of lack of maturation of the autonomic nervous system. And many of our babies, as Steve knows, are born even before the third trimester, which is when the vagal nerve really begins to myelinate. So we're dealing with very, very tiny, very, very immature babies. And when these pauses in breathing are minor, then sometimes the baby recovers on his or her own. And that's typically what we refer to as apnea of prematurity. Sometimes the nurses will actually have to go in there and stimulate the baby a little bit. But there's also a phenomenon in which a baby, and often the antecedents to this are not well recognized, but it will appear as if the baby has suddenly dropped his heart rate, stopped breathing, and you need to do a major resuscitation on this baby. Now, the way I'll find out about it as a physician is that one of the nurses will come to me and will say, "Baby Jones just had a death spell." And that is exactly what they call them, death spells. As I have begun to understand polyvagal theory better, I have understood that this is a baby who went from who knows what had gone on 2 hours ago. Maybe mother had the baby in kangaroo care, nice and safe and calm and secure. And then perhaps she needed to leave. And then the baby is transferred back to the incubator. And the baby often becomes tachycardic. What does this sound like? Does this sound like a vagal brake sort of releasing and then a baby becoming sympathetically mobilized? And then when the baby has exhausted his capacity, exhausted it to generate any kind of energy for recovery, he develops this profound bradycardia and prolonged apnea. And I think that was the point at which one of the points at which I realized the profound relevance polyvagal theory had to my work as a neonatologist.
Let me just add that polyvagal theory evolved from the vagal paradox, and the paradox is really quite simple. How come heart rate variability or respiratory sinus arrhythmia, which is vagal, is protective, and bradycardia, which is also vagal, is potentially lethal? Mm-hmm. And that was the question that I posed to try to figure it out. And the answer actually became emergent when I started to essentially read all things vagal and start going into, I had an appointment at the NIH and would go into the bowels of the library and just read stuff. And I actually, as we all find, the interesting stuff is not the book or the journal we're looking for, it's the one next to it. And I started to read material on comparative neuroanatomy. And start to realize that reptilian neuroanatomy really was a better representation of that preterm and of the fetal heart rate. And then I started to get into this interface between maturation, development, and comparative neuroanatomy, and start to look at autopsy research on the myelinization of the vagus. And you can map exactly the time periods of the fetus or the preterm when this is vulnerable. So you can actually see that. In fact, I'm still doing research on this. And recently I did a paper where I employed a new metric that I called vagal efficiency. And that you can see developed during this last trimester. And it really enables, vagal efficiency is really telling you how effective is that vagal brake in changing heart rate. So not only is the vagal brake important, you actually have to evaluate how it's dynamically doing its job. And you can see that developing. And as it develops, you get differentiation in autonomic state with sleep states. And this is showing an autonomic nervous system developing. I don't want to elaborate too much, but my portal into the polyvagal theory, or my stimulant, where it was exactly what Marilyn is talking about. And I felt that neonatology had good observers, but they didn't go to the next level. They didn't ask the mechanisms for why their beat-to-beat variability was of use and why were type 1s and type 2 bradycardias useful. They didn't go into the neural mechanism. They were observers, and in not going that next step to identify the neural mechanism, they couldn't put a different reality to it. So it just became a clinical test and not an understanding of a mechanism leading to vulnerability or optimization of development.
So there's an interesting comment in the chat here. Ray Kelly has said, Steve, that he's on a trauma surgical ICU rotation and has noted the erratic heart rate and respiratory rates. Also sounds like some of the patients that we are taking care of with severe brain injuries. So,
well, I mean, from a polyvagal perspective, this is very predictable, because what he's seeing is really how is the brainstem regulating the viscera, and the brainstem is getting chaotic, and that means that it's getting signals that it's really under great threat, and this may be due to hemorrhage or something else going on, but we see this output in the autonomics in terms of heart rate patterns and breathing patterns. The rhythmicity of these systems are indicators of homeostatic regulation. So the feedback loops from brainstem to viscera and back from viscera to brainstem tell you a lot about health. And this is really the point where I want to make this important statement to my medical colleagues. And that is, as the medical world has focused on end organ damage, not on neural regulation of end organs. And so people will say, oh, the heart tissue looks great, or the kidney looks fine, or they look for the damage in the end organ as if that is the antecedent of disease, or that's the locus of disease. But in many cases, I'm not saying in all cases, the antecedent can be dysregulation of that organ, faulty feedback loops. And those feedback loops that regulate it to states of homeostasis are always going to be compromised during chronic or toxic stress, when there's a diversion of the resources from homeostatic functions to defense. So the mantra of polyvagal informed medicine is keep the autonomic nervous system out of states of defense.
Which is a really hard thing to do as a resident. And so what you just said about babies in the NICU with all the noise and the input and the stimulus, and they're just trying to do their best to develop, that reminded me very much of personally being in residency and watching residents go through all the stress and the stimulus, and the fact that they can't remove themselves from that situation is also similar to babies in the NICU, just the lack of control. What are some ways that you might suggest as we go through the process ourselves of being sympathetically activated, being in fight or flight, and then going to sometimes even into immobilization and burnout? Are there ways that you think we can?
Well, let me interrupt. I'm sorry to interrupt, but
No, I was done. You're great.
The world that we're living in is exactly what you're describing. It believes that productivity is increased by putting greater demands on individuals, because it has this naive inherent belief that if you don't put pressure on the resource, the staff, work won't get done. People are inherently lazy. That's not really the case for many of us. We're inherently curious and motivated and want to be helpful. And it's the stress that gets, or the demands, or the way that we're treated that compromises our ability as a resource to others. So we have to really start taking a much more optimistic and positive view of what it is to be a human, that our nature of being humans are not really to grab and to take, but really to be welcoming and supportive of others. And part of polyvagal theory emphasizes this connectedness. And this is what Marilyn was talking about in terms of the patient doctor relationship. Well, it's a person-to-person relationship. And this is how our nervous system, so in our evolutionary journey, we move from asocial reptiles to social mammals. So social behavior became a biobehavioral mechanism. It changed our physiology. And we have to become smart and realize that that's what our nervous system needs. It needs this reciprocal, synchronous, reciprocal social engagement. We need to feel safe. This forces us to re-understand what we mean by safety. Our culture does a horrible job with that. It wants teachers to carry guns to make our schools safe. Guns are not signals of safety. Removal of threat is useful, but that's not sufficient. We as mammals need cues of safety. We need cues of what makes us feel safe, and that is intonation of voice, the welcoming of another, in a sense, the accessibility of others. It's not just the words, it's how we use the words, it's how our presence, going back to Marilyn's Norman Rockwell painting, that's who we should be. We should be engaging, and we should be, what I often now start to say is that we've spent very little time in our training to become a good witness of others. So the concept within mental health is therapeutic presence. Within medicine, it's always been therapeutic presence, the physician as a wise and sensitive individual. But we need to be able to give voice to our patients and give voice to others. Without giving voice, people feel marginalized.
So I could make a couple of comments as well. From a practical standpoint, I think, and my hope would be that as you walk away from this lecture, that you have taken with you or will take with you a permission to need safety. Because I think there are so many things in the medical environment where the sort of gung-ho action culture really derails us in terms of what our own basic needs are for our own well-being. Think about who you would consider among your own micro community of safety. And what I mean by that is that I would hope that for each of you out there, whether you be a trainee or whether you be a physician who's been in practice, or whether you not be a physician at all, that you could name at least 2 or 3 individuals with whom you feel safe enough that when you do feel that you are beginning to get sympathetically mobilized, you can communicate with that person, engage with that person, and allow that person to co-regulate you as well. I'm reminded of a vignette that occurred to 2 of my friends. One of my friends is a physician, a neonatologist like me, and the other one is an advanced practice nurse. And my neonatology friend had fallen through a plate glass window in medical school and had suffered severe injuries and it had chest tubes. And as you can imagine, was out of commission for a while and very traumatized. A few years ago, he went in a room to see a mother in the ICU who had chest tubes, and he froze. Fortunately, he had an advanced practice provider with him who recognized his freeze state and took over for him until he could regain his equanimity. And what I would suggest to you is become that person who becomes sensitive enough to other people, to their facial expression, to their prosody and cadence, to the way they are using language and words, that you can both provide that kind of relief and in turn look for others from whom you would expect that relief. I would also encourage us all in our medical systems to work very hard to identify those people early in their careers who do become terribly dysregulated. They often go on to be what people would call a disruptive physician or nurse. They are very devastating to the environment. And if any of you feel like you are somebody who becomes dysregulated enough that that could happen to you, please get help now, early in your career, when it's going to be available to you and when you're not going to suffer consequences. And I'm looking at the at the chat over here, Steve. So Sapritha says, this reminds me a lot of the body keeps score. Absolutely. Absolutely. How do we apply it in populations where the trigger for their amygdala, might be systemic issues such as racism? Okay. All right.
Let me kind of start with that, and you can, of course, polish what I'm going to say. In some cases, so like what Marilyn and I have been really emphasizing is the social component of regulation, because we evolved as a species that can rapidly detect that and downregulate our threat and our defenses. But when we are not or don't have that around us, how do we regulate? When we destabilize? And that's really what I think this question is saying. Also, certain people have thresholds to react, much lower thresholds, and they have less resilience in their systems. So there are, in a sense, onboard toolkits. And the most powerful one is breath, because breath is our gateway to regulating that ventral vagal pathway. So if we extend the duration of our exhalations, we are actually enabling the ventral vagal brake to have more effect on our sinoatrial node. The ventral vagal brake will actually minimize or neutralize sympathetic excitation. It will calm us down, and it will start slowing up our heart rate. So by taking slow exhalations, or in a dialogue, you would say to a person, tell me how you feel. And if they just start taking a breath after each word, you say, is it possible that you could extend the duration of your phrases? Or sing what you want to say to me, which is in a sense the same thing, extending the duration of exhalation, because that portal is available to all of us. And it should be a toolkit that we all have. So if we are upset in a certain situation, we don't have resource person, we can, in a sense, excuse ourselves, take a few slow, deep breaths and exhale slowly, then our physiology can shift. And we should practice that and see what it does to our whole perspective of the world as we extend our durations of exhalation.
I personally use voluntary regulated breathing practices. Fortunately, Steve introduced me to another friend of his, Pat Gerbarg. She is a psychiatrist, as is her husband, Richard Brown, and they offer courses on voluntary regulated breathing practices. There's also many online apps. Racism, wow. That is such a challenging situation, and one that my colleague and I struggled with when we were writing our book, talking about systemic racism, health equity, bias. And I think that if we understand polyvagal theory and apply polyvagal theory in our practices, in our child rearing, and in our relationships, we come to understand that so much of the sense of danger that people feel come from implicit biases that are developed early in childhood. You know, Rogers and Hammerstein had it right. You've got to be carefully taught. And I think that if we can begin to integrate our understanding of where the, in a sense, nascence or birth of these implicit biases are, and actively work and actively examine and reflect on our own behaviors, that's a personal response. Certainly medical schools and other professional schools are working very hard more at the systemic level, and I do hold out hope that our current administration will also assist us in this way. Two other interesting, fascinating questions. Jackie has—
Can I just say something really quick about the racism piece?
Please do.
I think, so if anyone is interested in kind of, I think what Dr. Porges' polyvagal theory supports, you see it everywhere. That's what's so interesting about this theory. And so if anyone's interested in kind of how the polyvagal theory can be applied to issues of our own internalized racism, and kind of how do we start working on that, Resmaa Menakem's book, My Grandmother's Hands, actually references Dr. Porges' work as again a foundational aspect of how kind of Resma Medicum takes that and applies it to issues of racism, which I think is really elegant and beautiful, and a really great book, and builds off of the kind of this wonderful explanatory model of Stephen Porges. And the next questions, Dr. Sanders, are awesome. Thank you.
So we see that Jackie has asked about, it's brilliant. One of the challenges appears to be that seeking safety and connection as an individual in medicine may be seen as a weakness rather than a strength. Oh, you are so right. Many years ago, I was talking to a surgical resident who told me with great pride that he was on call every other night, and I believe had been up for 60 hours at one point, and he loved it. And I thought, you fool. Medical training has gotten to be, I think, much more responsive to the social, emotional, and physical needs of providers. Personally, I believe that the movement of large numbers of women into medicine has helped. Women often have different kinds of family responsibilities. They have childbearing, they have pregnancy that are going to lead to some interruptions in training availability at times. And what I would say to you is, don't be afraid. I think it's possible to be both a source of, pardon me, let me put it this way. I think it's possible both to have the respect and loyalty of your team and to at the same time be kind and looking for ways to improve relationships. Nobody questions me in a code. I run a good code. My point is simply there that the two are not inconsistent. You can run a good code, you can be a good team leader, and still try to promote an environment of safety and connection. Steve, do you want to comment?
Yeah, I want to kind of generalize. First of all, thank you for the optimistic story, Marilyn. Having been in medical school as a faculty member, I have another picture. What happened is that medical school, like all other academic institutions, has a fiscal model. And that fiscal model puts pressure on interaction and culture. And in fact, many of my physician friends who are of my age or who have retired already actually retired out of anger because they couldn't practice medicine the way they wanted to. And they wanted to have relationships. They wanted to do exactly what you're talking about, Marilyn. But the pressure, the management on them, and these were senior respected people, and they were extremely frustrated. My point is that something is wrong with the institution, and it has to start with the education. And that's why we're so happy to be here. We have to really start saying medical education has to be changed, because you can't talk about social interaction as if it's some piece of fluff that doesn't have a code. It's the basis, it's the foundation, because the social interaction is a physiological intervention on that body. It makes the body accessible for other interventions, including surgery, including medications. A body under a state of threat is going to be pushing away everything you're doing to it. So the cost effectiveness of interventions is going to be mediated. And this is a psychometric terminology. It's going to be mediated by whether or not the body is safe enough to accept and to process what you're doing to the body.
Beautifully put. Beautifully put. And Sapritha has now asked about combining this theory with DBT, which is really, really interesting. I read something that was very disturbing to me about DBT. When I was looking at some things, I was looking up the diving reflex. And I read something about somebody suggesting using the diving reflex to the advantage of a patient in DBT who gets so quickly and robustly, sympathetically mobilized, literally putting their face in a bowl of ice water. And I recoiled. I'd be fascinated to hear about your comments on that, Steve.
I think I heard that one too. And the diving reflex is a functionally a dorsal vagal one. It's a shutdown response. It's a death feigning response, and that's why you knew that, and that's why you got very upset. It's because people misunderstanding vagal pathways think that vagus is good. If I get the vagus on board, I'm safe. But the vagus can also be a defensive structure or pathway, and so I think the issues are we need to inform. So when we start talking about neurophysiology, the primary neural pathway to the heart is the ventral vagus, but there are some residual or vestigial pathways that are from the dorsal vagus, because actually the vagal pathways that go to the heart in the fetus are actually migrating from that dorsal vagus. They're moving, and not all of them go on that journey. So some are left. So in a sense, it creates diversity in the population, and that population creates diversity in survival methods. And sometimes shutting down is a good survival method. It may be good one time, but this is where we get into actually like with the ACEs. The notion of shutting down is potentially lethal. That's the part that we know from understanding about neonates and especially preterms. We know it can kill you. But if you survive it as an adult, in a sense, you're under a severe life threat challenge and you pass out, you hit the ground and you survive. What's your nervous system going to do with that record the next time? Are you going to pass out again, have a low threshold? Or will your nervous system repurpose that immobilization response and give you a little bit of sympathetic juice? So now you just freeze. You can't move, but your muscles have sufficient blood to make sure that you're upright and that there's oxygen going to your brain. So you can start seeing motoric freezing, which is more frequently seen as potentially a very positive adaptation to having shut down earlier. Now, if a client has this freeze tendency, you tell them, well, look, your body's doing the best it can. The narrative becomes really a more heroic journey than this is something horrible. How do I get rid of it? So part of what I'm thinking about in terms of medicine is medicine has to shift from being evaluative as well. Remember, virtually all of medicine is about giving people tests and scaring them. And again, the narrative is if you scare them enough, they'll be compliant. And of course, that's not really what we're talking from a polyvagal perspective. We don't want them to be under states of threat. So what does that mean? It means that the information has to be conveyed through a joint journey of psychoeducation or of education. We need to basically create a collaboration with the patients. And Marilyn, I'm sure you're doing that with yours in terms of teaching them about the developmental trajectory of the preterm, the vulnerability. And if we go back 50 years and ask how were preterms treated and what happened to them, many of them were left as wards of the state. Why? Because the parents would come in, they would try to cuddle to their, cuckoo to their baby, and the baby was non-responsive. And they said, who's this baby? I can't attach to it. And they would come in once, not every day, every couple of days, once a week, and then they would just disappear. And the babies then became wards of the state. This is a true history. And things did change when people started to understand that even preterm babies with their limited behavioral repertoire were babies. They had a repertoire. Heidi Als's work really triggered this in terms of understanding that the babies could respond to stimuli, and they had this complexity, and the parents could then see the developmental trajectory, and they started to say, what a lovely and what a courageous child I have.
I think that's an interesting question. I think Suprita has another question about you have a lot of great questions that I struggled with too in terms of application. I work with a lot of folks who have chronic and complex trauma, and trying to figure out how to partner with them as a medical doctor, basically I can't. And I think that what your model has allowed me to do is really help folks feel that they are not broken and that nothing is wrong with them, that they have a very healthy nervous system that's trying to keep them alive, and they've been put in situations that have made it so that it's much easier for them to go into immobilization, or much easier to be in sympathetic all the time. And so it's super cool to have that as a base. But I think what's really interesting is that the things that were developed prior to the polyvagal theory have a much different take on what the right answer is, just as you're saying in terms of neonatal medicine. But I think that's true even with models like DBT. I have a ton of patients who feel really isolated by DBT. They feel worse after going through DBT, and it's great for some people, but there's some people it doesn't work for. And then there's this message that that's kind of like the end all be all. And if you can't do DBT, then that's it. But then you look to things like The Body Keeps the Score, which is based in polyvagal theory. You look to things like Gabor Mate's book, When the Body Says No, which is based in polyvagal theory. Like, there's newer models that are kind of coming out about what healing modalities might look like based on polyvagal theory that are very different than what has come before it. So I think it's really interesting.
Molly, the model really is that your physiological state, the state of your neural regulation of your autonomic nervous system, is that in between variable, that intervening variable that determines what type of intervention will be effective. The other part of what this discussion is moving towards is that people feel that if something worked for one, it should work for everyone, or they didn't do it correctly. And this is what some of the, in a sense, vested therapists will say, well, it worked for them, it's not working for you, you're doing something wrong. The issue, we have to start understanding that our physiological state provides accessibility. If our physiological state is a state of threat, the accessibility is very, very limited. And we need to, in a sense, pick up the features. And the features from a clinician's perspective is, what's the voice of your client? Does it have prosodic features? What's the facial expressivity? What's the muscle tension? Where's the eye gaze? Is the person looking away from you? Is the person's face flat? Is the voice, are they like whispering or barking at you? You know, and this is where Marilyn's talk is, how do you feel? Do you feel it in your body that this person is connecting to you or not? And when I give my talks, people will come up and they'll say, oh, thank you for your talk, I learned so much. And I said, forget that, tell me the truth. You didn't learn anything other than get your intuitions validated. And I'm saying that really to this group. You know when you feel safe and comfortable and co-regulatory with your patient. You know that. Now you have to just become more aware of the features that create the problems that you're not connected with others. And how can you start increasing the percentage that you connect with?
So I want to address Supreetha. I am by no means an expert in DBT. I am not a mental health clinician. I am a pediatrician neonatologist. It is clear, however, that there has been a big push toward manualized therapies, therapies that accomplish things quickly. The faster, the better. We all know what some of the pressures are in those areas. So the article that I read was not an official DBT manual. I want to be very clear about that. It was a commentary on DBT. In terms of chronic trauma, I would say that probably at least 60 to 70% of the population that I take care of is affected by chronic trauma. Like you all, I take care of a highly impacted population, at least 50 to 60% Medicaid insured, high levels of poverty, homelessness, low educational levels. And I would say that probably the greatest gift that I have in working with people in many different, who come from many, many different backgrounds, is curiosity. Curiosity will take you a long, long way as a physician, and being curious about your patient, asking questions of your patient. I often will ask parents of babies, for example, well, how did you come up with that name? And I get very interesting stories, very, very interesting stories. I view the polyvagal theory as a framework, a template upon which specific interventions or therapies can be built. I don't know how many of you know Debbie Korn's work. Debbie is a very highly regarded trauma therapist who works with Bessel in the Trauma Institute. As I understand, she's actually going to be one of his keynotes this year. She has co-written a book called Every Memory Deserves Respect that will be out in a couple of months. And Debbie, too, talks about the polyvagal theory as being a framework upon which everything else is built. It's foundational.
I think we're going to blush. Well,
I'll blush. Go ahead.
The beauty of it is that it's there for everyone. So it's not a branded intervention, it's a strategy. And that's what it was for. It was for other people to use to expand and to express their creativity. Because to me, it provided a greater understanding of what it is to be a human. And that enables us to, in a sense, optimize our own experiences.
So Sapritha asks again, how do you co-regulate with your patients without creating a sort of emotional dependency in your relationship with them? How do you set clear boundaries without closing the door to vulnerabilities? I have opted to have a complex psychiatric primary panel and have such a hard time with this. And boy, is it hard. There's no question about it. It's hard. I guess my own feeling about that, and I am not a mental health clinician, keep that in mind. So I'm not anybody's therapist. Is that I'm fine with my patients attaching to me. I'm fine with them in the short run feeling some dependency upon me. I'm fine with them feeling good when I walk in the room. The issue of setting boundaries, I think, is where the work has to be done with such patients. I think that if more people allowed patients and encouraged patients to attach to them, there'd be a lot better compliance. There is actually some work that has been done looking at medical patients, particularly those with diabetes, and it's very clear, for example, that certain attachment styles are less compliant than others, dismissive avoidant particularly, have very difficult times relating and being compliant. So it's a matter, as Steve says, of looking at the patient in front of you, bringing a toolbox to the table that you can draw upon, and trying to work with the patient and even asking the patient perhaps what works for you. There is a lovely article written by Gerritsen, and Gerritsen is an oncologist. And he wrote an article about an oncology patient who was coming into the emergency room constantly toward the end of his life because he was so fearful that he would be in pain and not be treated. And so there, after a number of visits, their tactic was rather simple. And it was basically to say, you know what, I'll be available to you. If you need me, I'll be available to you. And clearly that's not, you can call me anytime at 2 o'clock in the morning. But the interesting thing in that kind of situation was the patient never came to the emergency room again. What he wanted was reassurance that somebody would be there for him in his suffering, in his pain, that somebody would be with him. That is vague and perhaps not helpful, but.
Marilyn, let me add to this.
Sure.
I said that we need more time to learn to be better witnesses of others. And that what you're really describing is we need to be compassionate and not, the problem is that within the world that I live in, which is often the world of trauma, there's a confusion between compassion and empathy. Empathy operationally is you feel someone else's pain. That's what the research says. My brain lights up when you're in pain. Now, when we feel someone else's pain, the person who's in pain doesn't feel good about that because they've actually now hurt us. So that's why many people who are trauma survivors don't want to tell their story. They want to tell their story, but they can't because it's going to be hurtful. It makes other people feel bad. But when you develop the ability to be compassionate, which is that witness, without emotionally being hurt by the words, but being supported, being there for them. And what you're really saying about this case, the patients want someone to witness them and be there.
Yeah.
They're not going to exploit it. Their body needs the reassurance that someone is there. And I think that's missing. So much of our world is saying, you can take care of yourself, can't you? And if you don't, what are we saying to the person? You're inadequate. And we forget that this self-regulation is a derivative of our opportunities to co-regulate. If we have opportunities to co-regulate, we feel strong. We can self-regulate.
Beautifully said, Steve.
That's a really important struggle. The concept of, and I think we have to undo it almost in medical training, the concept that we are responsible for somebody else. The way that we are taught, that's our job, is to make their hemoglobin A1C be good. I have no capacity to control that, but I feel like I should. And so I think that word witness, and maybe the word attunement over attachment, that word of like, I'm going to hold space for you to do your own healing, is a different way of thinking about it, which I think the polyvagal theory also has helped me with. I still don't know how to operationalize it in clinic or like in my own heart. My mirror neurons go crazy, my pain, all the things happen. I think it will be a lifelong work that I do, but I think that idea of witnessing is really important because then it enables us to be there, be present, be attuned without being afraid of getting sucked in, which I struggle with a lot.
Molly, you're saying something else that's very extraordinarily important. And actually, this is a discussion that is really frequently a dinner time discussion in my home. And that is, I don't try to fix things. In your model, trying to fix things, you're taking both the power, you're taking the power from the patient, and you're saying, I can do that to you or for you. That's, surgeons often like to think that way, but surgeries fail. They fail when the body can't incorporate what the surgeon has done. And what we have to understand is that we are trying to support the patient's healing. We're not the healer. The patient has to heal. And the healing will only occur when that patient's body, nervous system, resources can recruit enough energy, and this is functionally energy, to do the right metabolic actions and to actually do its job. And the program for healing is inside the body. It's not the physician trying to titrate various chemicals into the body. If the body doesn't want that stuff, the titration won't work.
Steve, could you comment on vulnerable populations?
Yeah, well, I mean, the comments.
No, yeah, go ahead.
So like with the pandemic, we talk about traditional vulnerabilities, but in general, we miss trauma as a pre-existing condition. But we're learning, because what's happening is those who have the highest death rates come from those risk populations. We're seeing all that and we're mislabeling it. We're saying it's racial or it's something else. We're not saying that it's racial because the racial communities have been under chronic threat. We haven't talked about it in those terms. So the issue is the culture or the risk to populations have to do with whether the body of the individual is in a state of threat. But I will say, just as I was trying to say that the medical world is wrong or doesn't quite get it because it creates mobilization of its staff, it creates chaos in its hospitals and quote healing platforms. If you want to heal, get the hell out of the hospital as soon as you can. We all know that. If so just get out of there as quickly, because you're not going to get any sleep, you're not going to heal, because the hospital is set up as surveillance and cleanliness, not in support of health, growth, and restoration. But we also know that universities are not about creativity and exploration and camaraderie. It's all about productivity. It's all the same model. We all know about what elementary schools are about, and we know that the child's nervous system is telling us exactly what those schools are about. Kids don't want to go to school. They have gut pain. What's that telling you? Their bodies are telling you they're in states of threat. But what do we do as concerned parents? We say, oh, you have to go to school. You'll get over it. We don't understand what our bodies are telling us. Our bodies are telling us that the world that isn't structured to support who we are. And we know what we want. I mean, you know what you want in your clinician-patient relationship. We know what we want in our mentor relationship. We know what we want in our attachment model or theories, and our children. We know what we want in our friendships. And we need to, in a sense, kind of change the template upon which we're all being forced to pass through. I mean, I often say that, I've survived academics. Well, I thrived in academics. It doesn't mean that I liked the way academics were run. I liked what it was able to give me. It gave me opportunities to learn, to discover, and now to have impact. But the impact aspect of what I always wanted to do is actually outside of being an academic.
Beautiful. Well, I just can't thank all of you enough for being here. Dr. Sanders, Dr. Porges, Randall, and Jerry for help setting this up, and for all of you for coming. I hope this sparks interest. I can, the learning of this, where it goes, the application of it, it's going to be a really exciting, never-ending journey for me personally, and for, I think, everyone else who appreciates this work. I would love to kind of keep working on this with all of you if you're interested. And just thank you both so much.
Well, thank you, Molly, and you're of course welcome to join the Polyvagal family, of which Marilyn is a primary partner in this. And Marilyn, it's always great to interact with you and bring me back to my roots in infants and neonatology and obstetrics, where I really came into these questions 40 years ago.
Thank you so much to all of you. It has been a privilege and a pleasure to have this conversation. I hope there are more.